I'll start with the quiz real quick.
Good morning.
Good morning.
We are done here in Altus. I don't know where y'all were still, if y'all were still quizzing or not.
We're done in Elk City.
Sorry, we're done in Lawton too. My mouse was not working. I couldn't click unmute.
Yeah, we are recording. Okay, so I may actually do it at the end. Mrs. Ward, I was going to make a couple of announcements, but I haven't gone through all my emails. I'm trying to make a list of all the students who are in physiology. So I'll do that, and then I'll confirm that list at the end. The two reasons I needed to know if you were in physiology this semester. One is because if anybody is taking the physiology here at WOSC, first of all, I want to know if I have anybody extra here on Mondays. So I think right now maybe just the one student from Elk City. And then also, I'm assuming that most of you, it looks like if you're taking it here, you have that Wednesday lab. So we're going to make sure that when we do clinicals for those basically five clinicals later on, October, November, we'll make sure that we do those. Clinicals will be on Tuesday, not on Wednesday. So with that being said, we have hidden that schedule that y'all saw for probably a brief amount of time. Basically, hopefully we should not be changing where you're going to clinical. Your time slot might change. So we'll be posting that schedule probably in another week or so, but we want to make sure those physiology people, we're not making you try to go to physiology lab and to clinical at the very same time. So that's my reasoning kind of behind that. Plus, I do at the end of the semester, make sure that those of who, if you're taking physiology, especially if you're taking it somewhere else other than here, get those transcripts in as soon as you can, because we have to make sure that you do pass that successfully before you continue on in nursing 1129 in January. So anyway, that's all I have for now. So Mrs. Ward, I will turn it over to you.
Yes, and I apologize still to the other campuses because my instructor camera is still offline. So you guys are going to get to see my students during the lecture, but I just want to make sure you guys can hear me okay.
Yeah,
Wave your hands if you can. Everybody can hear me good? Okay, all right. So I'm going to use some PowerPoint presentation. I know that chapter 2, we were doing work on your own Wednesday with that. So you should have at least either read the chapter or gone over some of the resources for that.
Line, but I'm assuming
Just that one. Is it on the back? Sorry, it's just on the back.
is that okay? This is the back side?
Yeah.
Okay, I thought it was the
All right, so sorry about that. So we're gonna go to chapter 2. And let me actually share my screen. Can you guys see my PowerPoint at the other campuses?
Yes, we can.
Okay. All right. So we're going to just quickly go over theory, research, and evidence-based practice. I just want to say that, we really didn't do like an intro to nursing lecture. We kind of just went straight into asepsis and all of the handbook stuff and the syllabus things. So I just want you guys to kind of understand that, nursing is so unique. It's unique because we provide a service to individuals, to communities, to populations, to families, based on knowledge and skills. So that's why the first day of class, we were sitting in here and we got some information and we went straight to the skills lab. So we're pretty much going to have equal time learning about things as we are performing skills. So I do want you guys to know that everything that we do in nursing is for promotion of health and wellness and improving patient outcomes. That's the one thing that we need to do. So how do we improve the quality of care for individuals. How do we do that? What are the steps that we need to take? Well, how do we find that out? We find it out by using research theory and evidence-based practice. So I'm just going to go over just a couple of things I noted here, let you guys ask some questions about some of the material. This is going to be a really quick lecture and just kind of a thumb through, since this was a work on your own Wednesday lecture. So I'm not wanting to spend a whole lot of time on this, but I do want to be available for questions, okay? So we are responsible for care, the self-care process. So how are we going to teach our patients, or how are we going to teach our individuals that we're taking care of to take care of themselves? And then how are we going to coordinate that care if they need other, maybe they need other services, maybe they need to be in home care, maybe they need physical therapy, maybe they need other disciplines to help them. So our job is to kind of coordinate that care so that we can help that patient have better outcomes. So we not only go over just basic care as far as just caring for them medically, but we do the physical, the emotional, spiritual comfort, and we always put their physical pain, discomfort in the forefront. So those are all those considerations that we do when caring for our patients. We have to adapt to those psychological and physiological changes that your patient is going to exhibit at any moment. So the more knowledge we know, the more experiences we have, the quicker we are going to be able to adapt to that, because we're going to kind of have this expected outcome or expected change, because we know when you do this, this happens, or we know if we do this, we're expecting it to happen this way. Sometimes it doesn't, but we need to be able to adapt to those changes pretty quickly. We kind of have to be that emotional support related to those high elated feelings that mamas have whenever they're giving birth to those babies. We also have to be there for those teenagers, those adolescents that are going through developmental changes and they don't understand their body and they're like, why am I like this? What is going on? Sometimes people have poor health conditions. Maybe they got a diagnosis, a prognosis that's grim. We have to be able to help them handle those emotions, and we have to handle those emotions ourselves too. Kind of have to put our own emotions at check. If you have a sudden or even a long-term illness, that is really trying on a patient. So we have to be able to emotionally support that, and also the death process, and then the grieving process after that, because you might have a patient that comes in that is really, really sick, and maybe they had a recent loss. They're still in their grieving process. And so it's not only handling the immediate death, but also the results of death. So we need to be able to help and support those emotions too. We also need to understand the meanings of health and illness and those other concepts. We have to understand it. If we don't understand it, we're not going to know the interventions that we need to do. We're not going to know the processes that we need to do. So we do this basically by doing our research, constantly studying. Are we up to date? Are we doing these? Is there scientific research out there? Do they have these clinical trials going on? Are they looking at the hospitals, and are we collecting that data, and what are we doing, and how are we making changes for the good? We must always have cultural sensitivity, linguistic sensitivity to others. If we can't understand our patient, we still have to be sensitive to that, and we have to show some compassion and kindness, especially if they're culturally different than us. We have to put our own thinking at the door and our own preconceived ideas at the door to help care for that patient better. Because if you've got any barriers up, you're not going to care for that patient as well as you could if it was somebody that I thought was pretty similar to me. Health literacy. Does anybody know what that term means? Health literacy. So if you have somebody that maybe has a 3rd grade reading level, but they're 65, and you're going to go in there and teach them about a medication. How are you going to do that? We need to make sure that we understand the level of health literacy. What is their literacy level? And we need to make sure that we're teaching to that level. Okay, you might even think that you've got somebody that might have a master's degree in, agribusiness. And you might think, oh, I can use big words. They've got a master's degree. You might could use big words ag-related, but you're not going to be able to use big medical terms for them to be able to know it, to know and understand it. So the medical terminology, that health part of it, we need to make sure that we bring that down to the level and make it very clear. So we also do a lot of decision making within hospitals. I think the majority of the hospitals are ran by nurses. The doctors just work there, get a paycheck, but the nurses run the hospital. You have more nurse managers, you have more nurse leaders, you have more nursing administration. So really that decision-making process, a lot of the times is ran by nurses. So you're going to have to be able to do some quick decision-making as little as at the bedside and as maybe 10 years down the road when you're managing a unit, or 20 years down the road when you're this CNO, Chief Nursing Officer at a hospital. We need to be mindful of social policies based on health, on patients' health. Think about this, social policies. What do you think that would relate to when you think of social policies? What does that mean to you? Social issues. Think about abortion. That's a social issue. Think about transgender. That's a social issue. Think about those kind of things. We need to be able to understand what that is for us to know what the effects of their health is going to be. And then we need to be able to care for them appropriately. We need to be extremely mindful, and we also need to be really good advocates on access to care. Can people in rural Southwest Oklahoma, if they have a heart attack, how far is it? What's the longest distance they have to go before they can get a cardiologist to see them? Do they have access to care? Do they have health insurance? Do they have means to get there? Do they have transportation? Access to healthcare. We need to be big proponents in making sure that everybody has access to healthcare. It's their right. Everybody needs to have access to healthcare. And the quality of care that healthcare system is giving them. That's very important. We want to make sure that quality of healthcare is super, super important. And then also we want to talk about the environment and the prevention of any kind of diseases. When we're talking about that, when we're talking about CDC and all of those things that changed our environment when COVID came, and so no, this is how the environment's going to be. All they were doing was trying to prevent disease and trying to prevent the spread of disease. And that's what they did. A lot of nurses went together. I mean, there were meetings after meetings after meetings right after COVID hit. I was still working at the hospital, and we were just like sitting there going, what are we going to do? This is what the state wants us to do. This is what the federal government wants to do. But what are we going to do as a hospital to protect our community? So the nursing leaders jumped in, nursing staff went in and said, this is what we need to do. We need to make sure that our environment is good so that we're not spreading this disease to anybody else that walks into our building. So no visitors, right? So those are some of the things that you guys need to be able to know, that as a nurse, that encompasses everything, okay? It's not just being at the bedside, that all of these things that we're talking about, these issues that we have as nurses, you guys need to be able to know how to respond appropriately. Again, like I said, the only way that you're going to know how to respond appropriately is to gain that knowledge. Okay, so there is let's see. So nursing knowledge provides rationale reasoning for nursing interventions. I know that I talked about that a little bit with some of you guys when we were doing a skills lab. We talked about nursing interventions. Those are the things that we do to help improve those outcomes. But the nursing knowledge that we have, that gives us the why. Okay. I'm one of those people that if somebody says, okay, this is what we're going to do, I always say, why? Tell me why. I need to understand why. Because if you don't understand the why, 90% of the time, you're not going to be compliant in whatever it is that you're doing. If somebody says, you can't hang that Foley bag on the bed rail. Okay, bossy. You know what I'm saying? So you're probably going to be like, well, I'm just going to hang it right there. It's more convenient. But if I say, you can't hang that Foley bag off a bed rail because it's higher than the bladder, and the urine in the bag will go back into the bladder and you will give your patient a UTI. Are you ever going to hang a Foley bag on a bed rail? No. So you always answer that why. Answer that why, ask that why, so you know why it is that you're doing something. Because there's a reason. Somebody studied it. Somebody had research. Somebody collected data. Somebody said you could give your patient hospital-acquired infections, CAUTIs, catheter-associated UTIs. That only happens in the hospital. So those are the reasons for our nursing intervention. That nursing intervention is appropriately putting that catheter bag where it's supposed to be. That's an intervention. That's just an example. So we develop that nursing knowledge by through development and research. And basically we gather all that knowledge by developmentation, asking those questions of why, and doing research. So we have the rationales come from a whole bunch of different places. So they come from regular anatomy, human physiology. How does the body work? How does the body respond to things? When we do this, what happens when we do this? So we get that information from those disciplines. We also get it from chemistry, from nutrition, from psychology, from sociology. That's why do you think you need to have those classes before you come into nursing school? Because that's a basis of how we gather that knowledge and how we get that information so that we can formulate good nursing and interventions based on all of those disciplines. So there are several different types of knowledge. We have traditional, authoritative, and scientific. So traditional is passed down from generation to generation. So a lot of times you'll hear this. Somebody will say, well, why do you do that? And the response from the nurse will be like, well, because we've always done it that way. I don't really know why. That's the way we do things. Why do you miter the quarters on the bed when you make it? I don't know the answer to that, but I know that that's how we've always done it. I don't think anybody really knows the answer. So that's kind of that traditional knowledge. So a lot of times you'll get that knowledge from older experienced nurses, people that have been in the nursing field. That traditional knowledge is also kind of those tips and hints to make your job a little bit easier. You know, still doing it the correct way, but just kind of doing it in an easier way so that you can be more quick and effective. So that's traditional knowledge. Authoritative knowledge comes from experts in their areas of expertise. So if you have somebody that has 10 years experience in OB, and they say, this is what we're going to do, this is what we need to do, kind of going to trust 10, 15 years of experience that's the truth, right? So you have kind of this authoritative, it's more like a vetted thing. I've been doing it for a long time. These people are also experts. Maybe they've gone on and they've gotten their certifications in OB. Maybe they've gone on and maybe they have their master's degree. Maybe they're nurse practitioners and they work in women's health, right? Those we would expect would be experts in that. Maybe somebody who teaches, maybe who does symposiums. These are people that we trust, that their experience, based on their education and their experiences, they know what they're talking about. So we need to listen to them. Scientific research is obtained obviously through the scientific method, okay? Sometimes those are all the thing about that is they are tested and measured. It's tested, we have a problem, tested, and we can have a measurable outcome. So think about that. So you know that it's going to be a scientific source of knowledge if you have a measurable outcome. All right, so let's go down to, so did you guys read about Florence Nightingale? Anybody read about her? Okay, somebody tell me something interesting in the Altus campus about Florence Nightingale that maybe you didn't know before, or something that you read that stuck out that was interesting or that you just didn't know. Maybe it's the first time you've ever heard that name, Florence Nightingale, before.
It was the first time I ever
Didn't know her?
Right here. Did y'all read that chapter?
from England.
She's from England.
She's from England, yeah.
Okay.
What time frame, what time period was she from? Anybody know? The
Like-
Crimean War. Somebody say wartime. What was one thing that she did? Does anybody from any campus, what is one thing that she did that changed the way our nursing practice? One big thing that she did and discovered that changed our nursing practice. She did start the first nursing training. Before that, she started the nursing training because at that time people were like, man, this girl knows what she's talking about.
Hand washing and cleaning.
Hand washing and cleaning, 100%. Miss Florence Nightingale was a nurse back in that time. It really wasn't popular to be a nurse, wasn't cool. But she kind of had this deep down desire to care for people. So she basically went to the front lines in the Crimean War to help these soldiers out that were coming in. These soldiers were not dying of injury from the actual war itself. They were dying from diseases and infection. And she thought, why is this happening? This guy has a cut on his arm. He should be living, but instead he's dying. We've got everybody in one room. So she collected data. She researched. She watched the other nurses. She watched the colleagues. She would watch the field surgeons come in there and she would monitor them. And she thought, you know what? I think it's general hygiene that's going to make a difference. So then she started implementing hand washing stations, taking those camelbacks and making the nurses wash their hands, even if it wasn't clean water, but she was making them wash their hands before they'd go in and touch the soldiers. She would go in and she would tell the nurses, she'd say, okay, we need to clean these guys. We're going to do bed baths. We're going to work on hygiene. And then she collected the data all afterwards, and the success rate of these people skyrocketed. She was saving people's lives just because she recognized the importance of hand washing and good hygiene for these soldiers. So basically, she was the first nursing researcher. She was the first one that kind of collected data, saw a problem, saw an issue, was paying attention, was going, why are these people dying? They shouldn't be dying. She collected that data, did the research, she found a solution to the problem, and she improved those outcomes. She's pretty an amazing person, I think. You're going to hear a lot more about her throughout your nursing career. And now that you're in nursing school, you're going to see a lot more nursing quotes and things. Later on, she did develop the first nursing trained program. So she does have a nursing school over in England. That's a bucket list of mine. I will go over there probably within the next couple of years so I can see that. It's still standing today. She's an amazing woman. Big, huge historical influence. She did definitely make a ton of changes in the way we practice nursing and kind of made nursing kind of cool, you know. I would think that those generals and those people that were over those soldiers were like, you're saving my boys' lives. I got soldiers now. So she made it kind of cool. All right, so we have intertwined clinical practices of what we call nursing concepts. So can anybody tell me what a nursing concept is? What's a nursing concept? Really easy. A nursing concept is an idea. Yeah. It's like an idea. So we have a group of, let me see, I got kind of sidetracked. All right, so we have, so what is the difference between a nursing concept and a nursing theory?
Concepts, the initial thought, the theory is contested.
Yeah, so theory is more like that pattern. Concept is like abstract. It's like, what if we did this? And it's just kind of this idea that's abstract. It's not really, there's never been anything like it before, maybe. And then you kind of constrict it into this reality. So you have, that ends up being like what we call like a conceptual framework or a model in which we do things. Now a theory can be tested. A theory has a pattern. A theory has specific guidelines. Theories are used in research, okay? So you've got, skip through those. So you have within nursing concepts, you have reasoning behind that. So there's deductive reasoning and inductive reasoning, okay? So you know that deductive reasoning considers, it examines like a general idea, and then it kind of considers specific actions, or it kind of considers those ideas. So it kind of just, it's just general ideas. Now, inductive reasoning builds from specific ideas or actions, and it turns them into conclusions, okay? So you usually start with deductive reasoning, and then you end with inductive reasoning, okay? Let's see here. All right, so I want you guys to know this. There are 4 concepts common to all nursing theories. So there's 4 common concepts. There are the person, the environment, the health, and then the nursing part of it, the nursing care. So typically those are the concepts that we're more worried about. The individual person, the environment in which that person's in, the health and wellness of that individual or illness. Health and illness is kind of intertwined there. And the nursing side, what do nurses do? So theories provides a mean of testing the knowledge through research, excuse me. And so it'll expand our nursing knowledge. So there are some, let me go. That talks about frameworks. I do want to talk about this. I don't think that this is in this slideshow. So there's several pertinent types of knowledge and their significance that are incorporated into any kind of recommendation. So once we find something, once we find a problem, we gather this data, then we find this recommendation of, okay, we need a change. So these are the pertinent types of knowledge that we need. So we have to have the science behind it. So that's observing, identifying, describing, investigating, and explaining those nursing events. The philosophy. So we have to also study that wisdom and kind of that fundamental knowledge that we already know and we're trying to build on. And we have to, and the process is used to develop one's own personal or professional viewpoint. So sometimes some of these research models might be a little biased because somebody puts their own personal viewpoint on it. It can also help drive passion to find an answer when you have a personal intertwine with it, right? A nurse should consider possible philosophy differences among your coworkers that could affect or impact the outcomes. Okay, so you might have a surgeon that has a different philosophy than you do, but you have to consider that their philosophy is different for different reasons. And you can't be like, oh, well, I don't know why he does it that way. There's a reason why he does it that way. If you want to know the reason, what do you ask? Why? Then you understand, right? And then the process. So a process is a series of actions, changes, functions intended to bring about a desired outcome. I don't want to go too far into theoretical frameworks, but I do want you to know that the most important concept of nursing theory is the person itself. Because what are we trying to do? Improve that patient's outcome. Our job is not to harm people. Our job is to help people. So we want to improve the care of people in clinical settings. We are going to use the nursing process. We'll go over that in the upcoming weeks. We're going to talk about the nursing process. We're going to talk about nursing diagnosis, nursing interventions, nursing assessments, nursing evaluations, nursing implementations. We're going to talk about all of that nursing process. That only allows us to be able to work better within our scope of practice. People will trust us more if we know the nursing process and we're able to find a problem, perform our interventions, find new interventions that are within our scope of practice, and then develop a better patient outcome. So it'll actually make our profession much stronger, right, as a whole, if we can do that. So here's that word, evidence-based nursing practice. So we're going to talk about that. I want you guys to just read about quantitative and qualitative research. So know what the difference is between those two. Know that whenever we do any kind of research, there is a tremendous amount of ethics that could be involved in that, right? So you've got a new medication and you're trying to find out maybe if this medication will help pregnant women feel better during their pregnancy. You've never given this drug to a pregnant person before, but now she's pregnant, she's got a baby. How do we know it's not going to harm it? There's kind of an ethical thing here, right? Okay, so there's a lot of ethics involved. Not just that's kind of the risk to benefit ratio situation, but you have to make sure that the people that you're studying have been consented to be studied. They have to say, yes, it's okay for you to study me. You can't just randomly study anybody without their knowledge. It has to be a fair subject selection, so you have to get your demographics equally. If you're trying to, do a study over women and UTIs in that group, you need to make sure that demographically they're all equal. So you need to make sure that if you're truly wanting to know research, do Hispanics get a higher level of Hispanic women get a higher level of instances of UTIs than African American. So if you're going to look at a group of women, you need to make it equal. If you're just studying one group, then you can just study one type of demographic to find the answers. And it has to be valid. Who is the person doing this research and what is their intention? Right? So quantitative and qualitative research. So make sure you know the difference in those. I'm going to go to evidence-based practice now. That's the last thing I'm going to talk about before we go to chapter 27. So evidence-based practice, you're going to hear that across the board. It's a problem-solving approach when we make our clinical decisions, and we problem solve by saying, okay, what does evidence tell us? Right? How do we do this? What's the best way that we can do this? Well, we do it because evidence says, okay, we want to make sure that that's the best evidence available for us to be able to problem solve. It blends not only the scientific part of it, which is why nurses love to say evidence-based practice, but the science of it, but also the art of nursing. And nursing is definitely an art. There is a fluid art changing movement, lots of colors, lots of facets, so that the best patient outcomes are achieved. That's our goal always. It could be specific nursing interventions that we use, or it could be just a set of guidelines that are kind of given to us. Especially if it's like to treat certain illnesses. And I say that like we have like a standard care plan that we do in a hospital facility. So if somebody comes in and they have congestive heart failure, there's a set of standards and guidelines that we do that we have to do every day, because we know the evidence says if you do this daily, if you put them on a low sodium diet, if you restrict their water intake, if you monitor their eyes and nose, if you weigh them daily, they're going to get better. So those are kind of the guidelines and the standards, and that's based on the evidence of practice that many types of disciplines have researched and found out this is what you're going to do all the time for this type of patient, because we know it's going to get them better. Okay. For treatment, certain treatments, so it's the same as like if we're giving a certain type of med or a drug, maybe we give it at certain times because evidence tells us if we give it at this time instead of this time, then you're going to have better outcomes. Or surgical procedures. So the use of evidence-based practice, it uses the analysis and systemic review of research findings, okay? This is how we implement it. Cultivate the spirit of inquiry. I loved the way that was typed out. I think I'm even gonna write it down on my whiteboard here. Cultivate a spirit of inquiry. That is that why. Why? Why do we do it this way? What's going on? How are we doing this? What is it? Ask questions. Ask the burning clinical question in PICOT format. That's really what I wanted to kind of go through here. So the 5 steps of evidence-based practice, let's talk about that first. So write this down. 5 steps of evidence-based practice you're going to ask. Ask a problem or question about the clinical area of interest or the intervention. Ask who, what, when, where, why. Collect is number 2. Collect the most relevant and the best evidence based on that question. Appraise. Look at the evidence. Appraise it. You know what that means? Find meaning behind it, right? What does it mean? Look at all that evidence that you've collected that's reliable evidence. Look at it, investigate it. Appraise the evidence. And then integrate. Integrate that clinical expertise. Integrate patient preferences. Integrate the values in making that decision to change. And then you're gonna, yeah,
It's the 5 steps of evidence-based.
EBP, evidence-based practice. Ask, collect, appraise, integrate, evaluate. And then decide, are we gonna change it or are we gonna keep it the same? There's kind of like a 6th one, but really just know 5. When you're evaluating, you're trying to look to see. So when you're asking that first question in the PICOT format, you have to figure out, who is it that I am worried about? Well, it's a patient problem or a population problem. So P stands for patient or population. I is the intervention of interest. Maybe it's the way you do a certain intervention now and you're really not seeing any outcomes. And you're like, why are we doing this? I don't think it makes any difference. And then compare. You have to compare it. If I did do this, or if I did it this way, is there really a difference? Am I making a difference? And then the outcome. Well, what happened? And then a time frame. So in this certain amount of time, maybe trying to think of something just off the top of my head, it's really hard. Maybe the first person that was like starting IVs and they had saline loss, which means that they're not hooked up to any fluid, but their IV is flopping around their arm and it's in the patient's bed, it's flopping around. Maybe the first time maybe there was a nurse that said, you know what? That IV is flopping around on that patient bed and they've been moving around and they haven't had a bath in 2 days because we've been short staffed. And I got to give them a medication and I'm just hooking up this saline syringe to that hub and I'm not cleaning it. Maybe our hospital says we only clean for 5 seconds. What if we did it for 30? Because we're still seeing bloodstream infections. Somebody asked that question at some point and said, we're going to scrub for 30 seconds. Why did we get to that number? Because 5 seconds didn't work, right? So there's a time frame at the outcome and the time frame. All right, so you guys will have some projects later on in the course of the next 2 semesters that you will have to have a gather journal articles, look up, you're going to have to research. You may even have a discussion post that will require you guys to be able to look up a journal article. You're not going to have a huge research project, so please don't panic yet. But there will be a time frame in which you're going to be able to look up some good research journals, research articles. So make sure that you're utilizing the resources in our Moodle page for you to know how to disseminate between what's a good journal and what's a bad journal, okay? Wikipedia is not a good reference for nurses. Anybody can go in there and edit it. Did you guys know that? Probably so, if you've taken any English classes. I can write down that Brandy's the most wonderful person in the whole entire world in there and submit it, and they could add it to it if they felt like that was the truth. So make sure that you utilize those resources. A lot of our stuff will be in the APA format. It's not the MLA that you might be used to. So APA is the format that we use. A lot of times you can get a lot of information through abstracts. You can kind of figure out, what is this research paper really all about? And is this what I'm looking for? Is this what I'm trying to find an answer for? But make sure they always have references listed. They'll typically have a discussion about it, which you'll find a lot of neat, good information in there when you're doing your your own research. the main thing is once you're doing research for whatever project that you have, make sure if it's really truly applies to whatever is the question that you're asking. Okay. All right. Do you guys have any questions about chapter 2? No? You guys good? All right. We're going to go straight into safety, security, and emergency preparedness. Let's sit down. I feel so bad that the other campus can't see me moving around and walking and using my hands when I talk. You guys are so quiet too. Makes me nervous. All right, so we kind of skipped from like chapter 1, chapter 2, and then we went to like chapter 24, and then we went 27. So now, but we felt like that this order is pretty important for you guys to go in, just so that you knew how important it is for us to maintain safety in an environment. Okay. We felt like that we wanted to kind of nail this into your brains early on. Okay. So there are several factors that affect safety itself. Developmental considerations. So is this a young toddler, child, right? Maybe lifestyle. You might have a patient in the hospital, or even they're at home and maybe they're an alcoholic, right? Maybe they've got risky behaviors and they're getting in their vehicle and they're driving. That's their lifestyle. Social behaviors kind of tie into that a little bit, but even further, if you have maybe they have, you might have a teenager with multiple sex partners. That puts them at risk. It's not a very safe practice, right? The environment of the hospital, the environment of the home, the environment in a school setting. Mobility. What if somebody has had a knee surgery? Or what if we've had a hip surgery? Or what if, they have tremendous amount of pain or back pain? Do you think that their mobility is limiting them and could be risky for them to injure themselves further? Absolutely. Talk about sensory perception. What makes you think of that? What would be a potential problem, Lawton? Deaf or blind, 100%. Even if they have skewed vision for whatever reason. What if they maybe just have swelling in just one eye? Do you think that might have a depth something as little as that? That could definitely happen. Knowledge. What if you just don't know what makes you, what if you just don't know? What if you just don't know that it's more dangerous to, this is a good example. What if you don't know when your teenage daughter takes a bath and she uses these bath oils, well, she doesn't know to rinse out the shower before mom goes in behind her, so I don't slip and fall in the shower, right? She didn't know. She wasn't trying to hurt me, but her knowledge was limited, right? She didn't think anything of it. That's okay. I didn't hurt myself too bad. The ability to communicate, right? If you can't communicate, if you're going to take care of lots of patients who are that don't speak your language, in all types of language, how can you teach them how to be safe? How can you explain to them how to be safe? There could be a communication barrier there, a huge communication barrier. Or their physical and psychosocial health state. So they may not even be in their right frame of mind. They could be acutely manic. They could be acutely depressed. They could even be, as far as physically, they may be in a coma or sedated because we gave them medications, right? Those all affect their safety. So when we're doing safety assessments, we want to focus on the person, the environment, and the risk factors that they have around them that's going to cause them harm or could potentially cause them harm. For example, you have an 85-year-old man, okay? He's in the hospital. It's his first night that he's staying there. He's been living at home by himself. He knows where his bathroom is at home. He knows where his bedroom light is at home. He knows where his phone is in case he needs it. He knows where he can find his slippers. He knows where all of these things are at home. But you put him in a hospital room that he's never been in, never slept in. He doesn't know where the light switch is. He doesn't know where his slippers are, right? A lot of times they're typically pretty embarrassed to ask for help. They want to be independent. Maybe he's 85 years old and he's there because he has an upper respiratory infection, pneumonia. So he's having difficulty breathing. So if he gets up and moves and he moves more, he's going to be short of breath. That's going to put him at risk for falling, for hurting himself, for injuring himself. He's going to have a decline. So that's the person. Now let's talk about the environment. So now we have ID hooked up to them. We have beds with bed rails that they always try to crawl up over. We have oxygen around his nose because he's because he's got pneumonia. He's got, what else could some factors in the environment be? Maybe the nurse forgot to put the bed all the way down. Maybe the bed is raised a little bit higher. Maybe it's too dark in the room. Maybe there's no, maybe he got wrapped up in could be wrapped up in his gown. A lot of times they get wrapped up and tacoed up. So those would be like the environment. And then there's specific risk factors. So anybody that's older, anybody that has had a history of falls in the past, we know that if they don't, let's see, what else? What are some other specific risk factors? Trying to think about our.
Could a risk factor be like someone that's obese, that they have their family coming in and bringing them fast food
Yes.
when they're supposed to be on a certain diet?
I think, it depends on their mobility. How do they ambulate at home? How they walk at home? I mean, definitely if somebody has been laying in bed for a long time or a couple of days, and it's the first time out of bed, they're going to be at that's a specific risk factor, a higher risk factor that they're going to fall or injure themselves, right? Haven't used their legs in a couple of days. Other specific risk factors would be, so I said a history of falls, maybe somebody who's older. Diane, what's another specific risk factor that you can think of? My brain is kind of somebody who's had surgery, a limb surgery. Maybe somebody who is getting opioids because of their pain. To kind of make you a little wobbly. Yeah, absolutely. Are you getting one or more drugs, within a certain amount of time frame that's causing you, that could be a risk factor. So a nurse history. So this is kind of what we were talking about. We need to make sure that we're assessing if they have had a history of falls. We need to make sure, do they typically use a walker? Do they use a walker? Or do they use a cane usually? And they forgot their cane at home, so now they're trying to walk by themselves. Any kind of history of drug or alcohol abuse. And then what do they do at home? Is somebody coming and checking up on you at home? Does somebody come by to see you? Does somebody make sure that you're okay? If you fall, what would you do? Yeah, I wish I could count the number of patients. It's so sad. I wish I could count the number of patients that I've taken care of that fell and was laying there for hours, sometimes days before they could get help. Like literally crawling to the phone, trying to get help. So check in on your people. So with a physical examination, we're going to do these assessments here. How do you walk before? Are you a ×1 assist? Are you a ×2 assist? Meaning, do you need one person to help you get up out of bed, or does it need two? Or are you completely immobile and are a full, we need to use like the lift. We have lift systems that we can lift our patients. Can they communicate? Are they able to understand what it is that you're saying? What is their level of consciousness? Do they know where they are? Are they confused? Are they confused? Make sure that you're identifying those potential safety hazards that I've been talking about. And then if there is any kind of concern ever that there's any kind of domestic violence or some kind of neglect, you need to always report it, and always document what you see, not what you assume. So there's several types of abuse. I want you guys, it starts on page, it talks about manifestation of child maltreatment in box 27.2. Talks about physical abuse, sexual abuse, emotional abuse, and neglect. In the physical book, it's 767. So we're going to be doing this assessment first, right? We're going to do the nursing process for maintaining the safety. So when we're doing that physical examination, we're making sure that we are trying to find anything that could be detrimental to the safety of this individual. Here's some, if a patient does have maybe a history of falls, all of these issues that we talked about earlier, that would put them at risk. We didn't mention one thing. What about, it says postural dizziness. What do you think that means? Positional dizziness. So maybe they lay down and they go to sit or stand up immediately, and all of a sudden they get really dizzy. A lot of times they'll just end up passing out, but if they don't pass out, they could even, even if they do pass out, they're going to fall, but they could still stumble on something. So that's one thing that can definitely contribute to falls. What could be some hazards in the home or the community? That could, what did you say?
Rugs.
Rugs. Definitely. Tripping over rugs, loose rugs. Do you know the number one, every single elderly woman that I know in the 60, about year 60 to probably 80, their dog. Oh, I tripped over little Daisy. She didn't mean to. She just jumped up, and then I lost my balance and I fell on my dog, or I fell because Daisy jumped up on me. Animals are a huge safety and fall risk, huge at home. And you don't want to come out and say, maybe you need to get Daisy somebody younger to hang out with. But animals, rugs in the room, maybe not that in the bathtubs, not having those rubber grippers, maybe stairs, absolutely. Maybe there's no ramp leading up to the door. So there's several different types of risk factor assessments. We talked a lot about falls. I can't talk enough about that because that's probably going to be the most common that you guys are going to be around. But let's talk just a little bit about fires. Obviously, we have our fire safety trainings, also poisoning. Do you guys know that we have poison control number, right? You guys, I wish that you guys got to meet Miss Jumper. She was my very best friend. I worked with her for years. She's a really great friend. She was a sophomore instructor last year, but she changed position. Her kids are very close in age with my kids. So our youngest two are actually like less than a month apart. And his name is Marshall, and I just love him, but he gets into everything. She has literally had to call poison control on her son like 5 times, and he's only 5 years old, for just various different reasons, like ingesting something. Toothpaste was one of the big ones. There was one that he opened up some toy thing and swallowed these little balls or something. I don't know. But she's like, I have the poison control number on speed dial. And I just, every time she says that, I crack up because I'm like, I've never had to call before. I don't even know what the number is. So there are definitely poison control centers. Anybody that has come into the hospital that they suspect has been poisoning, the nurses call poison control. Those guys are the experts, and they will literally talk to the physician, the provider, the practitioner, the nurse, and say, okay, what did they ingest? They'll do their little search and look up based on all their research that they did and say, these are the steps and this is the order that you need to do things so that we can get this patient out of there and better. So they will tell you step by step, okay, first try this, first do this, next do this. Okay, or call poison control. Oh, my child drank bleach. Go straight to the ER, and they'll tell you. And then once you get to the ER, they'll call poison control, or they'll have a standard protocol of which they need to do. So poisoning, that's a risk factor. What would be some risk factors for poisoning? We talked about kids. What would be some risk factors for little kids to get poisoned? Yeah, slime. Maybe not putting stuff up. Maybe not having locks on cabinets. When I was 2, I was I think I was about 2 years old. I was at a babysitter's house. The only reason why I know this is because I have a picture of me in the hospital in that little monkey cage crib. And I was like asking my mom, I was like, what is this from? She was like, oh, you were at the babysitter's house and you swallowed a bunch of diet pills. And they had to like make you vomit all these diet pills up. And I was like, oh, really? That happened? They were like, yeah. Or they thought you did it. They weren't really for sure if you did it or not. They couldn't really tell, but they took you to the ER. I was like, oh my gosh.
And then you go to a thing of kids gummy vitamins and ate the gummy vitamins.
Gummy vitamins. So they got a lot of vitamin C and vitamin D. So those are all kind of risk factors for poisoning, not having stuff locked up, not putting stuff away, maybe not doing education to your kids. Because when I give them a vitamin the first time and every time I'm like, now you can only have 1 or 2. You cannot have any more than that. It'll hurt your tummy. That's all you got to say the first time. They don't want their tummy to hurt. They're not going to do it, Suffocation and choking. So what would be some risk factors there for suffocation and choking? Plastic bags near kids or toys, or not cutting up the hot dogs, not cutting up the grapes, not having food appropriate sizes for our toddlers. Firearm injuries, huge issue. What are risk factors associated with that? Not having a gun cabinet, not doing education for the kids, not stressing the importance of the education of the kids, for the kids or for anybody. So we always want to identify real and potential unsafe environmental situations. My brother is a paramedic and his mind is different than mine. 100%. I've got this nursing mindset, this like, I find a problem in places and then I care and I like kind of this supportive person and this like doer. I think there's multiple types of nurses. There's kind of those big mama dog nurses that are like just, and then there's this other kind of empathetic, compassionate, not that they're not, but there's just types of nurses, but I'm kind of that one. I walk into a room and I'm smiling at people. I'm very trusting and I'm just looking, scanning. I'm still being cautious, but I'm usually pretty cool and chill. My brother, his whole thing is like he scans the environment for danger. Just where's the danger? It's like traumatic scene investigation, constantly everywhere. And so he really is always trying to find unsafe environments. And he's like, you have no idea what I've seen and what I've gone into picking up patients. And you don't even think that this could be a potential harm. But here we have a patient that we're having to pick up in an ambulance. And this is what happened. So he's constantly scene scanning, constantly. So once you identify those unsafe things, I challenge you guys to go to your own house today and see and look and be like, you know what, this might be a little unsafe. Maybe I do need to put some locks on these cabinets. Maybe I do need to put these up to where the kids can't reach it. Implement those into your home. Implement those into when you scan the environment in the hospital room. And after we're done with this, I only have probably about 30 minutes more of lecture for this chapter. After that, we're going to have some time until lunch. And I wanted each of the campuses, so Lawton and Elk City, to go into the skills lab room and really talk about and show them the environmental safety hazards of a hospital room. So we're going to look at it. We're going to see it. We're going to learn what it looks like and things like that. Really talk about it and reinforce this education. So use the resources available for safety. Let me exit this real quick and show you. Here is my show you guys something real quick. So this is some resources that you can use. This is that fall risk. This is one that some hospitals use. It's laminated card. So they'll have a new patient on here and a date. So if they're an increased risk for falls, they're going to check box. So do they have a history of falls? Are they on medications with side effects that could cause them for their gait to be off? Do they use a walking aid? Do they have IV poles or equipment? Remember how I talked about oxygen, IVs hooked up? Are they already unsteady? And then what about those that forget or don't, they're like, I'm too afraid to call for help. And they'll say that all the time. So the more of those check boxes that are checked, the higher of a fall risk that they're going to be. So here's what we're going to do. We're going to communicate their risk of falls all the time. We're going to make sure that they're using their walking aids every time we get them up. Every time we get them up. We're going to push or have the IV help them with assistance. So IV assistance when walking, we need to make sure that they're not walking by themselves with the IV pole, basically. Sometimes they like to hold the pole, but we need to just make sure that they've got either a gait belt on, and we'll talk about that when we go to mobility, when we're doing transfers in here. And we want them to have a gait belt on. It's a little belt that we can kind of hold on to so we're not pulling on their arms, right? We're not holding them around the waist, or we're not like pulling up their pants and giving them a wedgie. We have a belt that we put around their waist. So a toileting schedule. You know, you might go into a room, you might be doing something, and you're like, do you need to go to the bathroom? Can I help you to the bathroom while I'm in here? They might, and then they'll usually always say, yeah, I could probably go to the bathroom. And they'll get up and go, as opposed to you doing what you need to do, and then you leave, and then they're like, I should have gone to the bathroom. And then they try to go by themselves because they feel bad because you were just in there. And then they end up falling. So doing a toileting schedule, making sure that you assess, do I need to put them on a bedpan? Is this a person that I need to be walking anyways? Do we need to just do a bedpan? Or can we do a bedside commode? Maybe we can get them up to the side of the bed and then just shift them over and transfer them. Or are we going ahead and assisting them all the way to the bathroom? Are they capable of doing that? Bed alarm. So we'll talk about bed alarms too. So bed alarms are something that anybody who is a high fall risk, we're going to set that bed alarm so that if they get out of bed or start moving in the bed, there's going to be an alarm that pops up. And it's not only a reminder for them that they're in bed. If they've got severe dementia, they're going to get up anyways. But sometimes if they're like, oh yeah, I need to wait, it'll kind of stop them in their tracks for a little bit. But it'll alert the staff to go in there and help make sure that that patient is safely assisted out of bed. If they're on bed rest, if you have that bed rest order, because that is an order from a physician, you cannot get them up. Bed rest is bed rest. So are they a one-person assist or a two-person assist? So, all right, I just wanted you guys to see this. You'll see similar things in all of the hospitals when you go into the rooms. Every single patient you should know, it should be there. It's kind of a hospital standard that we're going to know what their fall risk level is. So that's just something we talk about all the time, constantly. Are they a risk for falls? Are they a risk for falls? And then we're doing those interventions to make sure that we're helping them out. I just wanted to show you that.
Yeah.
Oh, I'm sorry, I just realized, can you hear me, Mrs. Ward?
Yeah,
Were you screen sharing all of that?
I did. Did you not see it?
No, we didn't see it.
PowerPoint still.
Oh, okay. I am so sorry. Here. Can you see that?
Yes.
Okay, so I'm going to post this to the Moodle so you guys can see that. I am so sorry.
I'm sorry, we didn't say anything.
No, it's okay. It's all right.
It's
So
fine.
you see how it usually is laminated. You have, oh, you guys were just looking at patient outcomes for safety the whole time. I'm so sorry. I'm going to post this to your Moodle page so you'll have a copy of that so you can see it. But that's what I was kind of teaching too. All right. Chapter 27. Okay. All right, now you can see that same page that you guys have been looking at for forever. Oh, this is got the wrong one. First one. All right, so use those resources. That was a resource that I was talking to you guys about. You want to make sure that you're trying to prevent any kind of accidents. Does anybody know what ADLs stand for? Yay, activities of daily living. So what does that mean to you since you answered it? Walking, showering, brushing your teeth, cooking, just activities that you do daily that everybody does kind of mindlessly. And we definitely want to make sure that they're remaining injury-free. Some other things that we want to make sure that we're doing is monitoring a child's use of the internet. Too much screen time can not only cause psychological damage, it can hurt their eyes, they can have trouble sleeping. Whatever it is that they're watching could be harmful for them too, whatever they are using. So you want to make sure that that is being taught to children. You're seeing a total influx. I think I recently read an article that said children that are like by the age of 9 have already seen porn or some level of pornography. 9. So monitor that. Keep them innocent for as long as they can. Get involved in school activities and ask pertinent questions. You know, of course, it's a little difficult for us right now to get involved, but that's what we want to make sure that we're doing. We're making sure that our kids and community is safe. You can volunteer for safety committees. A lot of times every year they'll have, there were several times that I would go to my kids' school. I had a couple of books that I like to read to my younger kids. And so I would show up as a nurse. I'd show them my stethoscope. It's kind of a recruitment thing too. I'm trying to, recruit them young into nursing. And, just doing that it really does make a difference. And whatever it is that you're teaching them, it doesn't have to be formal. You can do it as a parent. I'm teaching them about, how to listen to their heart and their lungs and how to wash their hands and how to make sure that they're, keeping their hands to themselves and things like that. So you can volunteer for things like that. Those are some things that we can do in schools. Home safety, lots of education that we're going to be doing throughout this process. Car seat education, carbon monoxide education. Do they have a fire extinguisher? Are they like in an apartment complex or a building? Do you know where the fire alarm is located? Baby gates.
Mrs. Ward, are you showing us any pictures right now? I'm sorry.
Do you guys not see?
We see page.
Why is it paused? Do y'all see that? Gosh. Can you see that?
Yes.
Oh, now I
Okay.
can see it.
It was on the top. It said it was, I've never seen that actually. On the top, the screen part that says your screen sharing said it was yellow and it said it was paused. Oh, weird. Okay. So here are some safety devices that we're going to talk about back there in the skills lab when we're finished. What about safety considerations for neonates? So what's a neonate? Unborn, very, very small, fetal development. And then we're talking about somebody who's just been born, young, neonatal. So avoid behaviors that might harm the fetus. We're educating mom, don't drink or smoke. We don't want to leave the infant unattended. There was, I had my middle child, I was exhausted. She was a terrible baby. I never got any sleep. And so woke up, it was around Christmas time. So she was, that's irregardless. Anyways, she was probably only about 2 months old. And my husband got up my ex-husband got up in the middle of the night. He was up, she couldn't get any rest. So he just put her in the swing in this little, just a Mamaroo type swing or whatever. And he just laid her there. He didn't buckle her in. And then he was sitting on the recliner right next to her. He kind of had his hand on her. He ended up falling asleep. And all of a sudden in the middle of the night, I heard and this scream. And I jumped up out of bed and I walked in there and my husband's like this. ex-husband, he's like bouncing her up and down. He's like, she fell out of the swing. He was like panicking, and I was like, oh my gosh, is she okay? Is she okay? Is she okay? And I guess she had kind of, in that little Mamaroo swing, as it came up, she ended up just kind of bending forward, and she kind of went face down. So she just had a little bitty bruise on her forehead. She didn't have a huge injury, but I was like, you have got to always buckle her in. It doesn't matter how tired you are. He's like, I was just gonna lay her down for a second. I'm like, breathe, it's okay. She still doesn't sleep good. She's as cute as a button and really smart, so she didn't have any brain injuries. So you want to make sure that you're not ever leaving them unattended, or if you do walk away from them while they're sleeping or whatever, make sure that they're safe in their crib. Obviously, you don't have to be in there and watching them the whole time, but you make sure you're using the crib rails in the hospital as well. Want to make sure that you push those rails up before you walk away from those kiddos. Choking hazards, car seats, and we're going to teach them that they have to back sleep. So you guys can kind of go over considerations for toddlers and preschoolers. I think we've just kind of keep talking about it. Okay, keeps coming up. School age children. This is important, and I will say this, just because I have a daughter that is the same daughter that never sleeps, that hit her head. She also has severe asthma. She doesn't like to tell her teachers when she can't breathe. Like, she doesn't like to tell them. She's too scared to tell them if she's having trouble breathing or if she starts wheezing. She knows when she's wheezing. She'll walk up to me all the time. She's like, Mommy, I think I'm wheezing. I'm like, yeah, you are. Okay, let's get a breathing treatment. But she's too scared to do it. Thankfully, that's what happened Monday. Was it Monday or Tuesday? Yeah, it was Monday. Monday, I got a phone call, and it was my best friend is her school teacher right now, thankfully. So she called me and she's like, Parker's not breathing very well. So I had to call my ex-husband, breathing treatments, all this stuff. So make sure that you teach them how important it is for them to be able to tell somebody when they're hurt or when something's not right, or about the symptoms that require that. She knows what wheezing is. She knows that when she starts coughing more. She knows that when I tell her, if you're breathing really fast, that means that your lungs are getting sick. If you hear the whistle in your mouth, that means that you're getting sick. So you need to tell us. So you have to teach those symptoms. Immunizations are important. Obviously, stranger danger. Make sure you're teaching them about that. And seatbelt use. And practice those same things. They learn by mimicking. They learn by watching us. A nurse can sit there and tell them in the room, you really need to wear your seatbelt. And then they get straight in their car and Mommy doesn't wear a seatbelt. Brother doesn't wear a seatbelt. Are they going to put a seatbelt on? No, because I think it's okay. You guys want you to, we really won't go over a whole lot of this concussion, because we'll have a neurological chapter a little bit later on. But just know that that's a concern for our especially our teenage boys, teenage girls. There are definitely some repercussions for that. So just kind of go over that. Safety considerations for adolescents, gun safety, healthy lifestyle, STDs. Make sure they get their physicals. A lot of children or adolescents, a lot of things are caught because they got a health physical before they started doing sports. A lot of illnesses, cardiac issues, heart problems, lung, respiratory issues, maybe even, I think there was Dr. Pickett over in Altus. He's our orthopedic doctor over there. He volunteers to do the sports physicals. And there was a teenage boy. He was like, I've been having some pain in my thigh, because he's like, do you have any knots everywhere? They asked these series of questions, and it ended up being like a sarcoma, bone tumor, cancer. I mean, that was found at a physical, sports physical. That's it. So definitely make sure that you're promoting that. Guns and violence and internet again. That's a huge one. Internet safety. That's how they're picking up sex traffickers. That's how they're, predators lure boys. Oh man, I'm not going to talk about that. Did y'all see that Shawnee news story in Shawnee? Yeah, y'all look that up yourselves. So anyways, internet, phone use. They start driving at this place, right? Anybody else like have road rage sometimes? You need to really make sure. I don't think I've ever been down the road, or especially driving now all the time back and forth, how many times people are on their phone. And we all do it in this room. Every single one of us has done it at some point. We just really got to start paying attention to that, because we're going to end up hurting ourselves and hurting somebody else. It's just as bad as knowingly drinking that alcohol and not being fully committed to driving. So don't use your phone while you drive, please. Don't text. Don't look at Facebook. Don't post a big long thing on Facebook while you're driving, because your mind's turning. So let's talk a little bit about, let me see where I am on time. Okay, I'm good. Victims of domestic abuse. So what are we going to teach these people? How are we going to, I mean, they're a victim of domestic abuse, but they choose not to leave.
Just reinforce the idea that there is a way out.
Reinforce, educate. I mean, you can't convince them to leave a relationship, but a lot of times these folks are not going to leave. Not at all. But if they're there and they know they're going to stay there, give them a safety plan. What are you going to do if this happens? And that's what you can ask. If you're doing an assessment on somebody in the ER that comes in that is a victim of domestic abuse, ask them, what do your kids do when this happens? Where do your kids go? Are they away? Are they in another room? Are they watching it? Are they witnessing? What about you're pregnant? What if this happens and it gets out of hand and you lose the baby because he's punched you or kicked you? Happens all the time. What's your plan for that? How are you going to make yourself safe while you're pregnant? What are you going to do? If they're choosing to stay with that partner, that's their choice, but we need to help them get a safety plan in place. They need to have people on speed dial. They need to make sure that they have somebody that they can call, because there's nothing that we can do to convince them to leave. If you suspect domestic abuse, you need to make sure that you are documenting your findings, and we'll talk about documentation a little bit later on, but it cannot be biased. You cannot write down in your notes, that jerk came in while we were doing this. You can't turn it into that. It has to be what happened. You cannot add those things that you want to say, and you cannot, you have no idea. I mean, what the relationship is like. You have no idea what transpired or what got them to that point, and what hurts have got them to that point. Could be numerous things. So You just have to document what you see, make sure you do good documentations in case something does happen and your documentation is pulled because somebody ended up dying accidentally or whatever, could be subpoenaed in court. So make sure that you're doing that. So for older adults, after we've identified, we want to make sure that we modify those environments. These guys need to really, they need to, you know, they get to a kind of a point in time where they're like, no, I can drive, but they can't walk across their room or their living room without falling or stumbling. And it's like, your reflexes aren't too quick anymore. You're not as sprite as you used to be. So they need to make sure that they're at least somebody else is driving with them to kind of help assess to see if they're safe behind the wheel. So you can, you know, a daughter or friend, if you're whatever, suggest that. Usually a lot of times when they start realizing that they can no longer drive, it's because somebody was in the vehicle with them and we're like, they don't need to be driving. So make sure you're encouraging that. Regular vision and hearing tests, that's important. A lot of times their family practice physician will make those suggestions for them just to make sure that they're up to date and they're going to be safe. They're not going to have any vision impairments. A lot of times you'll see the elderly, they'll forget to turn off the ovens. They'll forget to turn off the burners, or they'll put, she'll be in the middle of cooking, you know, Granny's in there cooking and she takes that hand towel, she's drying off her hands and she just sets it over and part of it gets on the burner and then you've got a house fire. So make sure that they've got working smoke detectors. And then you will see in your career signs of neglect, possibly with the older adults as well. So we're not talking just children, but we're also talking about older adults. So you need to make sure that you're documenting that and you're reporting. And your facilities will have processes in place for that. But you want to make sure that you're reporting those signs and symptoms of neglect. So if they look like they haven't eaten, maybe they're malnourished, maybe they're even saying, well, you know, I have a neighbor that comes by and they come over to check on me, but you know, I don't have any food in the house because they've taken it or they've eaten it and I only have this much money and they needed gas, so I gave them money. That's always the case. Those elderly are financially abused all the time, and that is a form of elderly abuse. They're taken advantage of all the time. Well, I just gave them that. I felt so bad for them. They said their car broke down or whatever. So make sure that you're kind of documenting some of those things. Make sure that you're reporting if you're concerned. So there are falls prevention in every single hospital. Like I said, there's fall assessments. Those assessments have to be done every shift. Those are fall shift assessments. So you are reassessing your patient because when they came in, they might have been confused. They may have been on some medication. They may have not been able to walk. Maybe they had an order for bed rest. So they're at a higher fall risk. But now 24 hours later, you've had 2 shifts with them. Now they're awake, they're alert, they're orientated to person, place, and time. They know where they are. They can speak, they can talk. They're starting to move. They're a little bit more mobile. The physician now says they can get up and ambulate and walk now. And they don't ever use a walker at home. So are they at a higher fall risk like they were when they came in? No, they've made improvements. So their fall risk level may change as they progress through the hospital, both better and worse. They could come in walking and then the disease or something happened. Now we're having to give them medications that are causing them to be higher fall risk. So we do fall risk tools kits. There's falls prevention training programs that every hospital does. Here's that. Here it is, Altus, Elk City. I knew I had it in here somewhere. So here's that resource that you can use. This will help be a reminder for them too. I'm not going to go through the different fall risk models because every single hospital does something different. And sometimes they use their own models. But some of the things that we do, one of the main things is somebody puts their eyes on the patient every hour. And when you go in there and you ask them if they need anything, you can do that with them within that hour. So if you just walk in and walk back out, that's not very purposeful. That rounding is not purposeful at all. You're just walking in, looking, and leaving. You're not walking in and saying, oh, by the way, while I'm in here, let's try to go to the bathroom. Do you need your toothbrush? Do you need your phone? Do you need anything in your bag while I'm here? Do you need to order something? Do you need to, how are you feeling? Do you need some pain medicine? What is it that they need at that moment while you're in there? That's purposeful rounding. So RACE, that is for fire safety. So you're going to see that in every hospital training video from now until Kingdom Come. Every year, you're going to do annual training on that. So RACE is rescue, R is rescue, A is activate, C is confine, E is evacuate. So you rescue anybody that's near, you pull the fire alarm or call for help. You confine the fire, you close all of the doors, and then you evacuate safely as possible. A lot of times the elevators will not be in use during that time, so you have to use the stairs. Every bed has a little slide thing on the underneath portion of it. It's usually yellow, and all it does is it slides on the ground easier, so you can have like 1 or 2 people pull each mattress off of the hospital beds, and then you can take them down the stairs that way. A lot of times those stairs will also have wheelchair lifts that they'll be this like little machine. So if you already have somebody in a wheelchair, they'll be put in this machine. I love this. Diane, I think you know what I'm talking about. They have this little kangaroo pouch in the nursery that has like openings for babies. So they have these little openings. So you can put like 3 babies right here and they just kind of fit in there. And you can like rescue. It's kind of like a thing that you put over your head and you tie it on. And then you just put these little babies in these little pockets in case of a fire. Oh my gosh, I thought it was so funny. The first time I saw it, I was like, what is that? It's our kangaroo pouch in case there's a fire.
Have you ever had to rescue any patients in a fire?
No, but we've had multiple tornado. We have to get the patients to a safe area, but I've never had a fire situation. There was one night we were out in the hallways because of tornado activity for probably 2 hours. I mean, it was like there would be one storm and then another storm and then another tornado that was not far from us. And so here we are in the hallway, generators on. It's in the middle of it's dark in the middle of the night. We've got flashlights. Some lights work. So we're trying to find plugins that are red because those are generator specific hookups. So we're trying to like get extension cords to like plug everything in. We're getting oxygen, portable oxygen, so that we can use the oxygen for the patients in the hallway. So that's kind of stressful, but it makes for a good memory, I guess. Nothing bad happened. There was not a bad outcome, thankfully, but they were just funny. Actually, one night when my daughter was in the hospital for asthma, we had a tornado warning and we were out in the hallway there too. We just stuck her in a wheelchair and we were just rolling her around, just try to entertain her. It's like 11 o'clock at night. And she's hyped up on albuterol and steroids. Okay, I have about 10 minutes left. So this is, turn your brains on because this is important, okay? So shift. I know I've been talking a lot. I'm not very entertaining, I'm sure. So procedure-related accidents and medical errors. Okay, important. All right. So there are things that we do, and there's reasons why we do the steps that we do to prevent medical errors from happening. We don't know how to fix procedure errors or medical errors if they're not reported. You have to report when an error was done because there are safety mechanisms in place, okay? I want you to picture slices of Swiss cheese. Picture it, okay? Each slice is a step in the process, all right? So let's talk about when a physician orders a medication, okay? Picture it in your mind, slices of Swiss cheese. Everybody knows what Swiss cheese looks like, right? There's different sizes of holes in it, okay? Each slice of cheese, okay? So when a physician orders a medication, that's one slice of Swiss cheese. That Swiss cheese is spinning. So those holes are kind of rotating, right? So that order goes to the nurse. The nurse verifies it. She's another slice of Swiss cheese, right? She looks at it. She looks at the order. Yeah, that looks right. It's for the right patient. Yeah, I'm going to verify that. I'm going to okay that. I'm going to note that. That Swiss cheese is spinning. So you've got the physician's cheese, Swiss cheese spinning. You've got the nurse spinning. It may be spinning at different speeds. Next, that order is going to go to the pharmacy, the pharmacist. Pharmacist is a slice of Swiss cheese, right? That pharmacist is going to look at that order, prepare that medication, verify the medication, make sure it's put in the right person, right? So that Swiss cheese is spinning now, okay? It's verified, it's done. Now the carrier is going to take that medication up to the hospital, or it's going to be taken out of a machine that when you push a button, that machine pops out that med for that patient, okay? Pyxis system, that's how you guys will give medications in some places. That's a slice of Swiss cheese with holes in it, okay? So once you go and it's verified, there you go. Then you have the nurse that it's time to give that med. She's another slice of that Swiss cheese. Maybe she has 6 patients. Maybe that machine, let's go back. So she's going to verify that that's the right drug, and then she's going to go to the patient room. You've got all those slices of cheese spinning, right? And you just hope that each process lines up to where there's not an error that passes through, that those holes don't line up at any time. But it could happen. What if the machine was not serviced? What if the machine made a mistake? What if whoever the carrier was that got that sliced cheese spinning, what if that carrier maybe accidentally put it in the wrong spot? Maybe they put the wrong medication because somebody has to fill that machine up. So the next person, the next Swiss cheese is that nurse that's got to verify that medication. She can catch it at that point, right? But what if she's really busy? What if she has 6 patients? What if there's a nursing student up there and the nursing student says, what can I do to help? That nursing student forgets to grab her nursing instructor and the nurse says, just give this med. That's a hole in those slices of cheese. Maybe the doctor got it right. The pharmacist got it right. The first nurse that verified got it right. But somehow the hole on the Swiss cheese, think of the Swiss cheese method when you're thinking about that. I hope you can visualize that very well. So any time that we have a procedure that's ordered or a medication that's ordered, there is a risk and there is a procedure in place because they've said this has happened in the past. So we need to make sure that we've got everything lined up and we need to do it the same way every time in order to prevent those errors from occurring. So it can happen when we administer medications or IV solutions. It can happen whenever we're transferring a patient You think transferring a patient, what does that mean? Well, what if you transferred a patient from the ER to the ICU and maybe something was missed? Maybe there was a break in communication. You've got one nurse taking care of them, and now you're transferring that patient to another nurse, a new nurse, or a new provider, or we're transferring them from Altus to Comanche County, and there was something not right in the mix with the communication, and something time sensitive, time goes on, and then you've got an error that occurs, right? What if that nurse there forgot to tell them, oh, I gave them this much amount of IV morphine, or I've already given a full bag of magnesium, and they get there and they're like, well, the nurse didn't tell me she gave a mag. Let's go ahead and give more mag. That's a miscommunication that happens all the time. Medical errors happen all the time. All the time. Changing a dressing, that we could maybe do something wrong there, right? Even if you have apply heat to a patient's extremity, something as little as that, and we're talking about something big like a medical error, like miscommunication, but then you're talking about something as little as, I'm going to put this hot pack on the top of my patient's foot because they said that their ankle, but then you put it in the microwave and it's 200 and something degrees, and then now you've given them a 1st or 2nd degree burn. Okay, something as big as medication mess ups to operating on the wrong extremity or the wrong patient, because that happens too, to I'm just going to put heat on this because my patient wants heat on the lower end of their back. You put it on there, oh, that burns. And you look at it and you're like, oh crap, that just took off the first layer of their skin. That's an error, right? So you have to report that, okay? You have to report every event. And it's not to get you in trouble. It is not to tattle on yourself. You think that you might get reprimanded, but you're not. You have to report it. You have to definitely report it. I'll never forget the first time I ever had to report. It really wasn't an error, but it was a nursing judgment error. And I had a patient that came in, and they came in because they were having chest pains. The doctor ordered nitroglycerin that helps open up the veins, and he also ordered morphine, which is what we give for the pain. That also helps relax and open up those blood vessels to get oxygen and blood to the heart. And they also ordered aspirin. Well, the patient had gotten there the night before. He'd gotten all that treatment. He woke up the next day. He'd already gotten his daily aspirin, but he was complaining of a headache. He's like, this is the worst headache I've ever had in my entire life. The order on the EMR was morphine, like 1 milligram, very low dose, extremely low dose. Morphine, 1 milligram, IV, PRN, pain level greater than 7. He's like telling me his pain is 10. I was a very new nurse. I was like, man, got a pain level of 9, 8 or 9 or something. It was a time when the doctor, he didn't take calls certain times of the day because he had a meeting. Patients like writhing. I'm doing all my interventions too. I'm like turning off the lights. I'm asking family members to leave. I'm turning down the TV. I gave him a cold pack for his head. I tried to position change him. I'm telling him, are you a coffee drinker normally? Maybe this is a withdrawal. I'd already taken the nitro patch because a lot of times we'll put them up here. The nitro patch will cause headaches. I'd taken the nitro patch and put it on his thigh instead of close to his head. I'd done all of it. It was like 3 hours had gone by. I couldn't get this guy's headache to go away. I didn't have an order for Tylenol. Couldn't give him Motrin. Couldn't, and he kept saying, I feel like I'm going to throw up. And he started getting nauseous because his head was hurting so bad. So I thought, I'm just going to give him this morphine. I had a nurse tech with me. I pulled it up. I'm like, I'm just going to give him 1 milligram of morphine. I can't get the pain down. I have an order for morphine, 1 milligram. give IV, PRN pain greater than 7. He's got a pain level of 8 or 9 right now. So it's exactly what I was supposed to do. I hooked it up to his IV. I flushed, hooked it up to his IV, and I just set it there because I had told the nurse tech, I said, will you please get a blood pressure before I push this? So as I hooked it up onto the IV. I did not push it, but she was getting the blood pressure, and sure enough, his blood pressure was like 80/48 or something crazy ridiculous. His blood pressure was so low. Had I pushed that morphine, I could have bottomed his blood pressure out, which thank goodness I didn't. There's a process in place. There are certain medications that you need to know those blood pressures. Now, I was nervous. So, and I'm a very honest person. I can't lie. Did I tell your class this or the other class? I think I told the other classes. They were like, are you fibbing us? And I'm like, I'm a terrible liar. You can see it all over my face. So as soon as the doctor came up, I said, I was trying to find you, Dr. Lever. I have this patient and I don't think that I gave him morphine, but I did hook it up, but I didn't push it. I was trying to get an order for his headache. And he was like, why would you give morphine for a headache? And I'm like, because I tried everything else and there's an order on here for greater than a pain level of whatever. And I couldn't get a hold of you. And he was like, it's okay, Brandy, but I was thankful that we had the process in place for us to know that we're checking blood pressures before we give certain meds, that we're paying attention. But that was hard for me to just say that. And it wasn't a huge mistake. Patient was fine. I don't think any of them, the morphine went in, but I could have potentially caused a lot of harm. But I still reported it because then at that point, they added Tylenol on the standard. You have somebody come in with chest pain. Guess what? They get aspirin, morphine, nitro, Tylenol, and a stool softener now. So that's a standard that was added. Was it added necessarily because of me? No, but it was added as another option. So there's not just an opioid on there if your patient's experiencing pain, because headache pain is different than chest pain. So you have to event report always. It helps with processes. It helps improve processes. It helps the hospital improve. It helps create policies. It helps identify ways in which we can improve. It helps identify those bad apples too sometimes. I don't want that to defer you, but if it's just consistently happening on a certain time, on a certain shift, in a certain unit, somebody there needs to be educated. So then you can shift your education to that department or that specific time frame. So reporting events is important. You guys will get taught how to event report whenever you're in the hospital. I've had instances where students have event reported and there have been total changes in the way we do things, like created stickers for IVs because the nurses weren't popping the antibiotics and mixing the IV piggybacks at the bedside, and they were just infusing the saline and not mixing the actual drug. And the students were catching that. They were like, wait a minute, this antibiotic hasn't been given. They've just been given the normal saline in the bag. So now when you scan it, it pops up. Make sure you mix your antibiotics because it was happening too often. But if nobody reported it, you would never know. Then your patient wasn't getting their treatment. A lot of times that antibiotic therapy is time sensitive. You have to have it in a certain time frame. All right. And you don't, it's not mentioned. The event is not mentioned in the patient's chart. Just your patient's response. You don't go in there and say, the event is not part of the medical record. So when you're doing your event reports, it's not part of the medical record itself. So whatever you say in the event, the story that you tell, that can't be pulled over to the medical record. So when you're documenting in the patient's chart, you document facts. You don't say, well, pharmacy gave me the wrong med. That's not what you're documenting in the patient's chart. You're saying this medication was given, this medication was ordered. Here is the patient's response to that medication. Physician was notified, patient being monitored, da, 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 da. You're not pointing blame in patient documentation. All right, let's talk about independently campuses, about restraints. So I'll let Mrs. Fairchild and Mrs. Cook discuss restraints with the independent classes. Christy, were you able to find some?
No, but I'll probably show them a couple videos.
Okay, that sounds good. I think we've got some here that I'll show them. So you can use whatever resources are on here if you wanted to, but I think we need to go over restraints for the next hour. Safety in the skills hospital, and then restraints. And then that's all. You guys just kind of look over mass destruction, things like that. That's things that you kind of need to know, but it's not immediate things that you need to know. So I wish that you guys can see me, but do you guys have any questions over anything? We can take like a 10-minute break. So back at 11:15. Mrs. Fairchild, do you need to?
Yeah, I need to make a few announcements real quick.
Okay.
Okay, just FYI, this mainly would be for the Altus campus. They are having, I think, they have teamed with JCMH, and in the main building, we're having a COVID-19 vaccine. If you're interested in getting that and you haven't, again, mainly Altus people, because it looks like it will be done today at 1 p.m. But that is in the Pioneer Heritage Center. If any of you, this is for any campus, if you do have taken your COVID vaccine and you want to be entered into a chance to win some prizes, it's kind of an incentive that the college is doing to encourage you to get the vaccine. You can bring proof of your vaccine to the, let's see, academic support office. You might even, on the other campuses, you might even be able to, I'm not sure if you would want to fax that or scan it and send it to somebody in that office, but you can contact the academic support office and you can do that if you're interested. I think they're giving away a few prizes. I think one of them is like a book voucher. One of them is, I think, for like 10 free meals here. One of them, I think, is for maybe a partial reimbursement or something like that for tuition and fees. So anyway, I just wanted to make sure you knew that. You probably have received that in your school email. Are we still having discussion board issues as far as entering into the discussion board? Is anybody?
So what I want is on my, yes, I have not heard back from IT yet. I sent that message yesterday after yesterday. What I want you to do, if you're doing the response, click reply to my discussion on the board. So you're just going to reply to mine.
So where she has her.
Where I have posted it and I just posted the questions only. Click reply on the side. And then you can reply to any one of those. They can kind of be like a little tree down. Does that make sense?
We're not doing add a new discussion.
Do not add a new discussion. Reply to mine.
Most Altus did their own.
I guess everybody, a lot of people did. Do they add a new topic?
If they were able to, I can, like I said, I cannot get in touch with IT. They have not responded to me. So some people, for whatever reason, have access to add a new topic. There are some people that aren't able to do that. If you're not able to, just reply to my Just click reply to mine and put your response there.
Hey, Miss Ward,
Yes,
I have two that can't even see where other people have posted on the discussion board.
have they posted yet?
They haven't posted one because they can't post and they think that, and they're afraid if they reply to you, they still won't be able to reply to others because they aren't able to do that.
Okay, so this discussion question will be due next Friday
Okay.
until we can get it fixed.
Get it fixed.
That'll be good. I'm just moving it a week out. The first discussion will be due next Friday at 5 o'clock. Your first response or 2 responses will be due by that following Monday. So I'm just gonna move it out a week until I can fix it. I
Okay.
can't do much if IT's not helping me. I don't have a camera here. I don't have Wi-Fi here.
I'll make sure I give you the 2 students that are having issues.
Perfect.
I have a student who has a comment about this. Let me see.
So that happened to me yesterday where I couldn't see anybody's responses and I ended up calling IT desk and they got with me in about like 4 hours, but they fixed it and I'm able to see everyone's response.
Okay, well, one student was having the same issue, not being able to add the topic and not seeing anybody's replies. She called the IT and told them the problem, and within about 4 hours, they actually fixed it. So we might, if y'all are having problems, go through IT. That might be the best way. There might be just some kind of setting that is not done correctly for some reason on your Moodle.
Okay, it looks like I got an email about an hour and a half ago from Nick Cabin. I don't know how to do this, Ms. Fairchild. He said that a couple of students weren't put into a specific category group.
Okay, I just fixed that earlier this morning, so everybody is in a
Okay.
group now. And there
Okay.
was 2 students who were in Elk City, so that might fix the problem.
Okay,
She says it's fixed now, or one of them says it's fixed.
okay.
Everybody's in a group now, so. Okay, it sounds like we're, if you're still having problems, call IT. And then we will follow up with your instructor on Monday for sure. Okay, so the students I have for physiology, I just want to make sure I have everybody, and I've got several emails, so I may have missed one, but I want to make sure. So I have Connor Cherry, you are taking physiology, Kaylee Cryer, Michaela Jones, Logan Nunley, Lucy Ovale, Kiara Vaughn, and Kimberly Wolf. Now those are just in general. Is anybody else taking physiology in any capacity that I missed?
I have another one here in Elk City, Roxana Kiwi.
Okay, and now are you the one taking it here?
Yes.
Okay, and so is your lab normally on Wednesday at 1?
Yes.
Okay. And that you do know that you can come here after class on Monday. Do you understand that?
Yes. Yes, she does.
Okay, okay, very good. And then in Lawton, is there anybody in Lawton that's not on my list that I just called out? Okay, anybody else in Elk City? Okay, and here in Altus? Okay, did y'all respond to me? Right, I must have just missed them then. Okay, I'll get their names later for them. Okay, and then Lippincott wise, I have, it looks like 49 students have enrolled for Taylor's, your fundamentals resource. So that means that there are 2 people probably who have not yet at all. Any problems with Lippincott right now?
I have one that's gonna try again that still hasn't been able to use the class code.
I know that, so who in here cannot get on? The code, I have one student that said the code that she has won't work to get in the class.
Two different.
So 1, 2, 3. I have 3 students.
Okay, go ahead and give me their names real quick.
We have Jolie Lindsay, Stephanie White, and Sarah Eckroat.
what was the last thing?
Eckroat.
It works now. Okay. Anybody else?
Okay,
No problem.
Elk City,
It's just doing something weird with the browser, but I haven't tried it on my laptop yet, so.
you haven't tried, where are you trying it on? You said you were trying, it's with your browser, but you haven't tried it on your laptop.
I was using my iPad, but I'm gonna try it on my laptop and see if that makes a difference.
I think I have heard people who they do say it makes a difference. Also, I know if I make my Lippincott, my course point, if I enlarge it too much, even on my computer, it thinks that it's like I'm using a cell phone.
Oh,
And the iPads might be doing that, so definitely try your laptop.
okay.
But, okay, so is anybody in Elk City just having trouble with the class code?
Anybody else? I think we're all fixed now.
Okay, and then like I said, I have 49 enrolled. That means that 2 people are missing. I haven't had a chance to go through to try to see who's missing. So if you're having issues getting that resource, you need to let me know, okay?
Mrs. Fairchild, I'm having nearly the majority of my evening class is having some issues. So if you don't mind, when I log in with them at 4 o'clock today, do you think you can hop on and kind of help me understand what those problems are? And maybe I have their names still
Yeah.
listed that I sent you in the email.
Should be able to.
Okay.
I won't be able to stay too long, but yeah, I can be there for like 30 minutes. And hopefully it won't take
Okay,
long.
I don't think it'll take that long,
Yeah,
but
I'll try to resolve that.
okay,
Oh,
thank you for that. Because I think probably half the class can't get in or over half the class can't.
okay. I mean, I haven't even, you know what, that might, okay, yeah, I need to look and just see how many students have gotten on. Okay, I think that is all I have. So, I'm done. And
Okay.
well, thank you so much. We appreciate that. And it just FYI, and I mean, Mrs. Cook and you two, I found a really good site. I just kind of put in restraints, you know, in the Google engine. I'm trying to find the site now. Anyway, there's several. It's the registered nursing .org. NCLEX and then use of restraints. Anyway, it has a really good synopsis of what you might want to teach. So just in case you want to share
Can you
that.
say that one again?
Yeah, it's registered nursing.org /NCLEX. You want to just send y'all a picture of that?
Yeah.
Okay, I'll do that real quick in case you're wanting to use that.
Okay,
Okay, thank you so much.
thank you.
Thank
See y'all
you.
later. Have a good weekend. Y'all can take a 10-minute break and we'll come back.
For those that missed it, the sophomore class came in and they said their greatest study tool was creating a Google Doc that everybody could share and add their notes to from classes. So I created a social forum. In the social forum, a discussion where you can put your email address. Just make sure it's either your school address or a Google email address. And then I'll start the document and everybody can have access to it and add their notes. And if you want to be a part of it, if you don't want to be a part of it, I don't care. But just put your email address on there so I can add you.
So, do you think there's an easier way that if you can just like to join a class in the social forum, that way we can just add our notes, so we don't have to I mean,
That's a great
either
idea.
way.
No, that's a great idea.
Oh.
So if we're not joining something, we're gonna show it on there, or that I show it. Because I can still, I mean, I can look at the ebook.
Looks like you're right.
I forgot that we had combined the evening class. I was thinking of numbers, I had 49, but if I should actually have like 66. Still missing several. I think I do. Yeah, because it is a class thing, so that's part of the problem. Like, it seems like a lot of people who are having that problem, when they call us and never able to fix it. So maybe, have you tried calling?
No, not yet.
Try calling the hotline or, and then going from there. Okay, thank you. Oh, and there's a nursing club meeting on Monday at noon. So, what is the nursing club? Basically, it depends on how active you are per se, but it's just a club to, if you want to raise money for a certain cause, or if you want to, it's just a club with the students between freshmen and sophomores. We're gonna, they really want to do some activities this year. I know the college does a couple of different things in the fall. They do a pumpkin patch. They do, I think, like a Halloween type festival. And so as a group or organization, we can be a part of that. If I think maybe we're gonna even try to do some type of little fundraiser during one, not during the Halloween one, but maybe during the pumpkin patch. If we raise money, you can, some classes at the end of the year even actually purchase nursing pens for the sophomores. We've got different things with the money. If you want to donate to causes, there's just all kinds of things you can do. It's not effectively, it's not like you have to go and study another university or anything like that. It's more for fun. And sometimes they even have intramural type games. And so in the past, we've been up on that. Oh, yes, okay, that's a part, pizza, we will have pizza. Oh, so that can be your lunch between class and then. Of course, still class.
Yeah.
Like lunch, that's, that might be a deal breaker.
No, you gotta go get what to eat versus we will have pizza.
Yep.
Yeah, we'll probably have it in the little computer lab area. So, pizza for sure, and then they're gonna probably be voting, or y'all will be voting, so you wanna, I'll also want them to buy pizza for our Monday thing, when we have Diane Vermillion here with the testing and strategies, because that will probably, we'll get started at 8:30, probably will go on past to almost 1. And then we really need to go ahead and go into skills lab, so if we can kind of just take a quick break and y'all can eat pizza during our class. Hopefully that'll work. Anyway, we're gonna do that.
Okay, the link is posted.
That's a really funky one I found. She's like hiding. Like so oh my god. It's like the tiniest bit of velvet. Like in the freshman like that, a little bit of buzz. I mean, definitely you run over the spot you missed. Yeah, basically.
They grow fast.
She's not happy. She's like, I hope you die if you. So. Yeah,
Do you hold them or you try to like?
I just don't know. I want to wrap it. I can hold on.
She doesn't even want to.
Yeah. I take them from you. Monday. Just today, right? The 12th? I don't know how I want to manage, because I looked at the first exam and then the major quiz and the one chapters it would be on. And I don't know how I want to manage this schedule, you know, because there's a lot of chapters, like chapter 2 where we kind of do it ourselves. So I'm like, and then also the chapters are so long, and if we're only gonna have a couple questions from each chapter, that's kind of scary. You don't miss anything. Hopefully we get some sort of like, I've got all I need with the guide or the study guide. That way we don't feel like I have this.